Hello, I'm Fred Weinbaum. I'm the Chief Medical Officer and Chief Operating Officer at Stony Brook Southampton Hospital. Welcome to Focus on Stony Brook Southampton Hospital. We have invited today as our guest Dr. John P. Reilly. Dr. Reilly is a cardiologist who practices in Southampton and does interventional cardiology at the Cath Lab at Stony Brook Southampton Hospital. Welcome, John.
Thanks very much, Fred. Appreciate it.
Tell me a little bit about your background. What does it take to do cardiac interventions, and how did you come to Southampton, Stony Brook, Southampton?
Well, after medical school and internal medicine training, did my internal medicine training at NYU. I did 3 years of general cardiology training, and for subspecialty training in interventional cardiology, which is required now after you're in general cardiology, I went to San Diego at Scripps Clinic in La Jolla, San Diego, for 2 years there. I actually worked in a large multi-specialty center called Oxner Clinic in New Orleans, Louisiana, for about 16 years.
Many people have heard of the Oxner Clinic. It's a big setup. And what did you do there? So
I was doing interventional cardiology there.
Okay.
It is as we said, it's a large center. They established some of the first association between smoking and lung cancer there.
Wow.
They were some of the leaders in cardiac surgery and transplant in the Gulf South.
Sure.
There. And my senior partners were big leaders in that area in doing interventional cardiology and treating patients with stroke there. So it was a great opportunity to continue further training while I was there.
Now, we've talked about and used the term interventional cardiology. What do we mean by interventional cardiology?
Well, interventional cardiology really distinguished itself maybe historically from general cardiology. For years was mostly diagnostic and couldn't really make any active interventions until the late 70s.
Yeah, before that, it was all about diagnosing the disease, and then if there needed to be something done, you need to call a surgeon.
We would call surgeons who would come and help us out and do coronary bypass surgery.
A big sternotomy, a cut right down the middle of the chest, and exposing the heart and using, other conduits like the veins from your saphenous vein from your leg to do bypass surgery. But now we do something called interventional cardiology.
Right. In the late 1970s, they developed this idea of doing balloon angioplasty, as opposed to doing the open sternotomy, a small, thin catheter, a thin tube that might be about the size of the wire that leads from your mouse to your computer.
Okay.
That gets advanced up through an artery in the leg to your heart, all watching just under X-ray. And then through that tube, an even smaller tube is inserted into a blockage that might be seen in the artery, and that balloon is inflated to expand that blockage and open it up. And today we do something called stents.
Right. And what's a stent?
A stent is made out of a metal alloy. Okay. I think it's crimped down on top of the balloon, and so that we can position it in place. And then once the balloon is expanded, the stent expands with it and acts as scaffolding to hold the artery open and provide some structure where we're doing the balloon, and it helps keep the artery open. And it has been a great success in extending the benefit of the balloon angioplasty. And so for the last 20 years, doing stents in coronary arteries has been a big help. There are 600,000 or 700,000 interventional cardiology procedures, stents in coronary arteries, being done each year in the United States alone.
And so when you have a procedure like that, if all goes well, it's not the same as surgery, is it?
Not the same as surgery, right? So for open heart bypass surgery in 2019, people come into maybe come in the hospital and spend 4 or 5 days or so in the hospital, and a few weeks after that, recovering. For a procedure that gets done through the artery in the wrist, sometimes through the leg, they often go home the following morning, in some cases the same day, and feel kind of And the bigger problem is telling people to pump the brakes, make sure you take it easy, don't do too much beforehand.
So through the use of this type of technology, we've taken a procedure that otherwise would have required an open operation and been able to do that and send people home within 24 hours.
Within 24 hours, and it makes it much more accessible for a larger group of the population. You know, if somebody had a blockage in one artery, well, it'd be a lot to send someone to an open heart bypass surgery for one blockage, and that could get treated with angioplasty. And maybe patients who might be frail or have other conditions that make them bad candidates for surgery, so they might still be able to get through an angioplasty procedure.
So if your risk is too high for open surgery, you may have a suitable risk for this type of procedure.
It's a little bit like Goldilocks. If you're too high risk, it's good for angioplasty. If it's too low risk, it might be better for angioplasty. If it's just right, it might still be good for surgery.
Okay, so there are still patients that we recommend surgery for.
Yes. Okay. Begrudgingly, but yeah.
Spoken as a true interventional cardiologist.
That's right.
Just to get back, how would I know that I needed that type of procedure? What symptoms would I have? How would I present?
Yeah.
And then how would you tell that it was totally necessary? What does a cath lab do?
So what is a cath lab? And that is something kind of a quirky about cardiologists, where we call almost any area where we do something a lab. It sounds like it's experimental, but we've talked about the cath lab, the echo lab, and EP lab. They're just sort of the areas where we do those procedures. For all my patients who come into the cath lab, they come out and say, that looks like an operating room. It's just a procedure area.
Right.
And so the cath lab today is the place where we make the diagnosis about whether or not somebody's abnormal stress test or abnormal EKG actually signified a real blockage.
You start out with symptoms. What symptoms would drive you to take this test?
Most typically, people complain about a squeezing or a pressure-like chest discomfort. Right. Typically, that would happen more commonly when they're exerting themselves, carrying groceries in from the car, climbing up from the beach, jogging a little further or faster than they typically do. Okay. And so when that's exertion-related chest discomfort or pressure, or exertion-related shortness of breath out of proportion to their peers, their spouse, or et cetera, those are things that people should come in and pay attention to. And I should mention that that typical description covers about 80% of people. Right. But there are sometimes some atypical symptoms that people feel it mostly in their jaw or mostly in their arm. And women are more likely to describe some of these less typical descriptions of chest pain or chest discomfort.
So for people out there who have chest discomfort, sometimes it's heartburn or reflux, sometimes it's coronary artery disease. What do you do to sort that out? You take a history, some may be typical of one or the other, but still there might be a testing that you might need to do before you would go to a cath lab.
Right, because we don't want to go straight to the most invasive test first.
Right.
So we would take the history, kind of assess how likely they are to have blockages or not. We would look at their electrocardiogram, which we do in the office. Right. They lay still for a couple minutes and do an EKG. Then very likely we may order a stress test. And some people walk on a treadmill while we do the EKG. That's the most common type of stress test. Other people, we do some other imaging as well, which we call a nuclear stress test or an echocardiogram with a stress test to get some pictures to increase their accuracy of the stress test.
How does a nuclear stress test work?
So the nuclear stress test...
What does that mean?
That means you get an IV put in before they do the stress test. And you can walk on a treadmill. Some people who maybe have knee problems or back problems and can't walk very well on a treadmill, we have some medications that can help replicate the effects of exercise. Right. But while they're exercising, we inject what's a radioactive tracer.
Okay.
And that's what we're referring to as a nuclear stress test.
Okay.
We then take some pictures. It's a big, similar to like an X-ray camera. You lay it down on a table, and it takes a series of pictures of your heart to show where that medicine that we inject in the IV, is your heart picking it up equally in all segments of the heart. Because if there's a blockage there, it may not deliver that nuclear tracer as well, and part of the heart won't show up as brightly.
Right. And so that would show up sort of as a blank spot within the heart muscle.
Yeah.
And then I've heard about something called reperfusion. What does that mean?
Reperfusion is restoring blood flow to that area.
Okay. So
Perfusion is the normal flow of artery, and when it's missing flow, we open up a blockage to restore the blood flow and reperfuse it.
And so if you're doing a stress test with this nuclear stuff and you see one of those blank spots, you know, you don't know whether you've had a heart attack and you have just a piece of muscle that's not working, or whether you have muscle that's at risk of a future heart attack. So in that case, when you take away the stimulus of exercise or the drugs we use to reproduce exercise, that area fills up again. And so it's a defect that reperfuses, and that means there's an artery that's potentially at risk for causing a heart attack.
Exactly right.
Got it.
Right.
Now, Stony Brook Southampton hasn't always had a cath lab. How long have we had this cath lab?
So the cath lab just celebrated its second anniversary.
Second anniversary.
Last week.
And so you're here at a propitious time. This is our second anniversary. Happy anniversary.
Thank you very much. You didn't send me a card.
But I did bake you a cake.
You did bake me a cake.
What did we do before we had a cath lab?
So before we had a cath lab here, patients had to essentially get triaged on arrival to the emergency department to sort out whether they were likely to be having a heart attack or need to have an angiogram right away. And if that were the case, they would have to then get put back in an ambulance, or if they'd come by car, an ambulance called to get sent up to Stony Brook to get taken care of.
So now we do have a cath lab, and if you do come to the emergency department, there are some situations where we treat it like a emergency and do immediate intervention. What is that?
Absolutely. We started talking about the more elective outpatient evaluation of chest pain, but about half of the people who have heart disease didn't know they had heart disease before they showed up with their first heart attack. When people are in the middle of having a heart attack, the best treatment is to open that artery as quickly as possible, because the difference between the person I described earlier and the person having a heart attack is how suddenly that artery has become occluded. And when a clot forms in that artery and completely shuts off the flow, it has not had time to develop all the compensatory mechanisms that have taken care of that more elective person. So we have to very quickly get that artery open. So we're kind of under the clock. When that patient shows up to the emergency room, we want to get an EKG done in the first 5 minutes. We want to get that person in the cath lab as soon as possible. So we kind of keep track of how quickly we do that, because it's not that big a difference. A small difference in time makes a big difference in outcomes.
Okay.
So as compared to people who come to the hospital and get their artery opened in an hour, as opposed to people who it takes 2 hours to get to the cath lab, their risk of dying before they leave the hospital is almost 1.5 times compared to the people who get done in the first hour.
How are we doing in the Stony Brook?
We're doing excellently. So our mean door to balloon time is very close to an hour. And we're doing...
That means you come to the emergency department and we have a guide wire crossing the lesion in under an hour?
Right.
That's amazing. There must be a whole team working on that.
We do have a whole team. You know, it is as much credit as the cardiologists like to take. It takes a whole team. And I would first start off with our we have 2 nurses in our cath lab.
Right.
We have 2 OR technologists who work with us in the cath lab. Of course, the rest of the OR team who preps and gets ready. We have nurse practitioners who help us, but it starts in the emergency room also. It really takes a whole system of care to get that right, and to regard that as there's a unified goal between both the emergency room, cardiology, and the OR, which is where our Cardiac Cath Lab is.
Now, before we had a cath lab, we used to use chemicals to try and dissolve the clot. Is there an advantage to doing this interventional treatment over the chemical treatment?
There is an advantage. Okay. That's been shown in some pretty large scientific studies that primary angioplasty, making the angioplasty and stent the first treatment for people with a heart attack, gets better outcomes, lower risk of complications like bleeding and stroke, right, compared to using that clot-busting medicine that we used to use.
I know that some of our early patients were, one of our own employees, and it's often a good feeling to know that the life you save is from your own family and friends. And of course, we do see people right off the golf course coming in with chest pain, and they get that emergency treatment, and they're really, it's really life-saving.
Yeah, our community, I think, has a lot of advantages in terms of either being out on the water or taking right, walks on the beach. Our own wellness center have lots of opportunities right, to engage in a healthy lifestyle with all the farm stands, plenty of great opportunities for right, healthy fruits and vegetables. But the truth is that the risk of heart disease,
fast food instead.
The risk of heart disease in Suffolk County is the same as the rest of the right, country, and so it's all good intentioned and is very helpful, but we have to offer that service.
Tell me, what about the impact of lifestyle like smoking and things like that?
Yeah,
is that a big deal?
Smoking is a big deal, and I think that people often make a quick association right, between smoking and cancer.
Lung cancer.
But the risk of smoking and vascular disease is huge. People who smoke are 2.5 or 3 times as likely right, to have a heart attack, to have a stroke. As a vascular surgeon, the risk of amputation is much higher for smokers compared to non-smokers. And I often tell my patients who used to smoke right, that quitting smoking is probably every bit as impactful, if not more, than anything I've done, right, even the stents that I've put in.
Right. I do know that from the education you've given me that there are kind of 2 kinds of heart attacks. One kind is, what we call a STEMI. And that's the one you were talking about.
Yeah. That
emergency where we run to the cath lab. Now, STEMI stands for, if I remember correctly, ST elevation myocardial infarction.
Right.
What's the importance of the ST, the ST elevation?
The ST elevation.
What's that a sign of?
When we do that EKG, we
right,
talked about earlier, we name the different waves
right,
on the EKG, P, Q, R, S, and T.
Right.
And so that space between the S and the T, that ST segment,
right,
when that is elevated, that's a sign that the person is having a heart attack and actively having acute injury. It's happening now. Someone's in the middle of getting whacked with a bat
right, right,
or stuck with that, and so you have to stop that now, as opposed to jump ahead, the non-STEMI, the patient who comes in and they are threatening to have a heart attack or recently had a heart attack, but they're not currently having symptoms, they're not currently being injured, they're also at risk and will probably also need to have an angiogram,
right,
but does not have to get done with that same urgency
get them
of that
in
first person.
Lab in an hour and
right,
get the balloon opening the artery. When I was a young man doing my internship, I remembered that these kinds of ST elevation heart attacks were far more common than the non-ST elevation heart attacks. Now it seems it's the other way around. Many people I've heard attribute that to the reduction in passive smoking in the community and the general reduction in smoking rates. Smoking is directly toxic to the arteries, and of course that can trigger the disruption of the plaque and causing the thrombosis. But a lot of the patients we admit to the hospital don't have ST elevation heart attacks, and yet they're still having heart attacks and may need to go to the cath lab to open up some blocked arteries. How does that happen? Explain what's a non-ST elevation?
So a non-ST elevation, most likely, so the ST elevation MI, that patient has 100% occlusion of the artery.
Acute clot.
An acute clot. The patient with a non-ST elevation MI probably has a severe stenosis there, 75, 80, 90% blocked, that maybe temporarily became blocked with some clot, but our body's own process of dissolving that clot was successful in opening it up. So that patient may come to the emergency room and said, I was having pain for 2 or 3 hours this morning. I thought it was going to go away. I got in the car, I drove, but in the 15 or 30 minutes it took me to get here, I'm feeling much better. And we may see some other changes on their EKG. Maybe that T wave looks abnormal. So but we keep them.
Abnormal cardiogram, history of chest pain, but we don't see the ST elevation.
And so we don't see the ST elevation, and it's not acutely injured. And so we say, well, how do we sort that out? Explain what's going on with this funny T wave over here.
How do we know if they've had a heart attack?
And so then we draw some blood tests.
We do blood tests.
And we often draw a series of blood tests over a few hours. When the patients had the non-ST elevation MI, that injury that happened this morning in the shower, some of those cells that were injured open up and spill out some of the proteins that are inside. And we're able to measure the levels of those proteins, called a cardiac troponin. That's part of the muscle network that helps do the contraction of the heart.
That's a heart protein we find in the blood.
And when that's abnormally high, then that's a signal and confirms that person had a heart attack this morning. It may have resolved by the time we got here, but that person is still at risk of having another heart attack. And so that person also needs a pretty prompt evaluation. Most of the time, we do an angiogram for them also.
The day after, within 48 hours, 72 hours. There's no immediate rush, but unless the patient obviously has recurrent symptoms, but they ought to be taken care of because they're at risk for having one of these bad events.
Exactly right.
Got it.
Yep.
Now, of the patients we do, are most of the patients who come to the cath lab those ST elevation heart attacks, the ones that are dire emergencies, day or night, or are they the ones that are less dire but still need to be taken care of?
The majority are the less acute cases. You know, and that's true across the country. You know, the majority of heart attacks in this country are the non-ST elevation MIs these days, by probably an order of 3 or 4 to 1 type of ratio. So they're much more likely to have these non-STEMIs.
And that represents a real opportunity for us to take someone who's had an acute event, but is not in immediate risk of losing significant heart muscle, but who has a future risk over the next few years of having pretty bad outcomes and change their future.
Yes, and so I think that we want to change their future even on shorter term. So the person who comes with a non-STEMI, there's a good chunk of them who are at a pretty high risk of a recurrent heart attack within the next couple of weeks or 30 days if we don't take care of them acutely. And I'm an interventional cardiologist, and I will think first about the stent that I put in, but for the rest of those 30 days and for the 3 years or more afterward, talking about that healthy lifestyle eating, improved diet, stopping smoking, getting your diabetes under control and your cholesterol under control, participating in cardiac rehab, all those things make a big difference over the next 3 years.
Now, I know there are certain drugs and medications we use and we measure ourselves against as having delivered them to patients when they come in within 24 hours and prescribe them when they're discharged. What type of medications are we using initially, and what do we want to make sure our patients go home with?
Well, everybody who comes in, we think are having a heart attack, gets an aspirin up front.
It's an aspirin.
And most of the times the EMS is delivered
a simple Bayer aspirin, big deal, right?
Right. Seems pretty easy and over the counter.
It does seem easy,
but very important,
yeah.
to getting aspirin. We also give people a cholesterol-lowering medicine up front, and it's one of those cases where many times people will say, "I've never had high cholesterol," or "I've always been told my cholesterol has been has been normal before."
Right.
And the important thing is about individualized patient care, and so. Yes, while maybe your cholesterol has been 190, which is not so terrible, but for you, you've just had a heart attack. And we've just found a very tight blockage. So we're not going to use the generic American population recommendation. You need to get your cholesterol level lower. Because that's been also proven that being on a cholesterol medicine prevents your risk from having a heart attack going forward.
And there are some drugs I know that are used that reduce the heart's need for oxygen. I mean, the arteries are delivering oxygen, I get it. An artery gets blocked, not enough oxygen is going to the muscle. The muscle needs oxygen to actively relax and contract thereafter. If there's not enough oxygen, the muscle develops an oxygen deficit. I guess like you're running, your leg gets sore when you're running. And by the way, if you run too much beyond that point and your legs start swelling and muscle starts dying, that would be like having an attack in your leg.
Yeah.
So I get it, lack of oxygen. But there are ways, I understand, where we can actually reduce the heart's need for oxygen, controlling rate and inotropic setting. What kind of medication do we use for that?
So we use mostly a class of medicine called beta blockers, and you're getting at the, I'm a cardiologist, not an economist, but it's supply and demand.
Exactly.
Right? So we focus a lot on improving the supply by opening up the blockage, but we can control the demand the heart has, because the more the heart beats, the more frequently the heart beats, and the higher the pressure it has to pump against, and the tighter it's squeezing. All that takes more energy to do, just like stepping on the accelerator of the car.
Exactly.
So if we can put a regulator on the engine by giving a beta blocker and having our heart not ask our heart to do too much initially, that's an important medicine in the first 30 days after a heart attack.
So at Stony Brook, Southampton, we want to give you an aspirin when you come in with one of these heart attacks. We want to get you to the cath lab, open up your arteries. We want to get you on a lipid-lowering drug, get you on a drug that will reduce your further need, your heart's need for oxygen, like beta blockers.
Right.
And when we send you home, we're going to want you to control your lifestyle, not smoke, do a prudent diet, control cholesterol, go to see your doctor afterwards.
Right.
And cardiac rehab. You mentioned cardiac rehab. What is that?
Cardiac rehab, it doesn't sound like that much, but it's incredibly important, actually. Cardiac rehab, we have one here in the Wellness Center on the 3rd floor. We recommend it for people after having a stent, after having a heart attack, if you're hospitalized after heart failure. It's 3 times a week for an hour of supervised exercise by some of our nurses and physicians who are here in the hospital. So we can set goals for how quickly you should be able to ramp up your activity level after one of these life-changing events. And some studies have shown that people who successfully complete 12 weeks, 36 sessions of cardiac rehab will do much better than people who don't. And it's not just the exercise. There's looking around and seeing that there are a lot of people just like me who
It's
also
kind
have had a heart
of,
attack.
you know, one of the things that I enjoy when as a hospital employee working in the hospital, seeing people coming in, you know, you see these crowd of people who are going up in the morning for cardiac rehab. It's sort of like a club, you know.
Yeah.
And they enjoy each other's company, and they seem to have a good time doing it. And they're very happy to be part of that program. I know, and thinking about it, if I had just had a heart attack when I was, you know, playing tennis, let's say, suddenly developed chest pain and ended up having a cardiac cath, I'd be afraid of going back on the tennis court.
Yeah.
How would I get the confidence to go exercise again, to know that I could do it? And when you say supervise, what do we do with people who are exercising, who are going into this process of post-op rehab?
Well, first of all, a brief examination, like checking their blood pressure and their pulse when they come in. How are you feeling today? Do you feel up to doing it today? Watching their EKG, particularly in the first few weeks, while they're doing the exercise.
Look at them, monitor them a little bit while they're exercising. And if you build up your exercise tolerance while you're being monitored, it'll give you the confidence to get back on the tennis court.
Yeah, I was successful doing it upstairs on the third floor. I can do it out here in the driveway or at the tennis court.
Absolutely. I think that's all sounds like really good advice. Now, all these steps require contact, require going to the office, requiring knowing who to go to and how to get access to the system. Where's your office? How do we get in touch with you? What do we do? Where do people go?
Well, I think, as you said, you know, when people leave the hospital, if they're hospitalized, we make sure they have all our contact information and set them up with an appointment for early follow-up. That's the time when we can make the greatest impact on their care afterward. We're just down the road here, about less than a mile away, I would say.
Great. Where's that?
It's right next to the brand new cancer center, that beautiful building there.
On County Road 39.
County Road 39. We're 2 doors up from that Stony Brook Cancer Center, Stony Brook East End Specialty Care, and we're across the street from that Porsche dealership there.
Okay.
So we're right next door.
So that should be easy to get to.
Yeah.
It's really a whole team that's making this work, starting in the emergency department, including our CCU staff, and led by the interventional cardiologists, you being a key example. It's something that, you know, I feel truly blessed that we have this at Stony Brook Southampton Hospital. It's great for the community, and personally as a resident in the community, I can feel very comfortable knowing that you all work together so well and so hard. Look, I'd like to thank the audience for being with us today, for sharing the time for the focus on Stony Brook Southampton Hospital. I'd like to thank Dr. John P. Reilly, and we affectionately call him JP, by the way.
Right.
I'd like to thank JP Reilly for being here and for coming into our community and for helping us achieve the great results that we have. And I'd like to thank CTV for allowing us to share this time with you. Thank you.
Appreciate it. Thanks very much, Fred. Thank you.